Hello there, I'm Swami Iyer from Houston. I'm here to discuss and give you a 1-minute highlight on the AML program that happened here at SOHO in September 2016. It's a very exciting time to be in AML. For many years you've seen this disease, which is so complex, but because of advances in biology and the new drugs, and also trying to combine them together to personalize the right treatment for the right patient, we have this slew of targeted agents. And you can see that today's approaches have changed quite a bit. But I want to, before I get to that, show you what we have done very well in the last 40-45 years. One good story that should always be told is acute promyelocytic leukemia, where the first targeted therapy was used with ATRA and arsenic, and now you have a survival curve that looks parallel to the x-axis, and that's fantastic. And you can see the 5-year survival rate is almost 100%. And how have we done with the rest of the acute myelogenous leukemia? It's been 45 years since the inception of 7+3, the 45th anniversary since it was first studied. But since then, lots of modifications have been done. And what I will show you, though, in a particular type of AML, which is the core binding factor for patients less than 60 years, here, in comparison to the historical data at MD Anderson, we have done much better by making the 3-drug regimen fludarabine, cytarabine, and the idarubicin. So for all the young patients, that's probably the best way to go. Outside of that, I think we have to resort to targeted therapies, and I will talk about, or at least highlight, 4 of the targeted therapies that are discussed at this meeting. This resurgence of the anti-CD33 antibody drug conjugate is of importance. This is a slide on gemtuzumab ozogamicin, the meta-analysis of 5 AML randomized studies. Despite the US study that was a negative study, there are 4 additional studies in Europe which showed an improved survival advantage. And this is making a resurgence with the SGN33 compound and the AMG 330. So you will hear more about this, and very likely Mylotarg might get a reapproval very soon. And the second exciting target is FLT3, and this RATIFY was a plenary session at ASH last year. And one of the reasons for that is this midostaurin in combination 7+3 showed a survival advantage compared to placebo. And one point I want to highlight here is all these patients had FLT3 mutation status, whether it is internal tandem duplication or TKD. And it appears that the patients with the TKD had a favorable outcome with this combination. And this drug, again, might get an approval early next year for AML. And the third targeted therapy, which is very exciting, is the IDH2 inhibitor. It's seen in about 15 to 20% of all AMLs, but this is data presented by Dr. Etan Stein and Courtney DiNardo. You can see about 200 patients who have the R140Q mutation or the R172 mutation. The response rates are pretty impressive at 17%, and these patients have achieved what's called as a clonal remission, which means you still see the mutation but have attained CRs at other levels. And finally, I want to stop with this very important slide. You heard the story of the PD-1 inhibitors in melanoma and non-small cell lung cancer. This survival curve is very similar. This is a study comparing azacitidine with Nivo in patients with AML with the historical controls. And you can see the blue curve, which is the Nivo curve, is the median response rate is about 9.3 months, far better than the historical controls. And perhaps we will start seeing patients who may not achieve the CRs but yet have a longer survival, as was reported with PD-1s and other malignancies. So these are some of the highlights on targeted agents and the context of chemotherapy in acute myelogenous leukemia. It is an exciting time, and I thank you all for this opportunity to present these highlights.